Good evening, everyone. Welcome back to our Life in Motion monthly webinar series. I'm Caitlin, and joining us tonight are Dr. Schroerlucke and Dr. Hauser. A little about the both of them. Dr. Schroerlucke and Dr. Hauser are board-certified, fellowship-trained orthopedic surgeons with extensive experience in both operative and non-operative treatments of spinal disorders. They share a special interest in minimally invasive spine surgery and bring advanced skills in managing complex spinal conditions, including but not limited to deformities, trauma, and degenerative diseases. Dr. Schroerlucke earned his medical degree from the Medical College of Georgia and completed a spine surgery fellowship at the San Diego Center for Spinal Disorders, where he treated a wide range of pediatric and adult spinal cases. Dr. Hauser received his medical degree from the University of Tennessee College of Medicine and completed a combined orthopedic and neurosurgery spine fellowship at Duke University, gaining comprehensive exposure to diverse spinal pathologies. Both Dr. Schroerlucke and Dr. Hauser share a deep passion for patient care, committed to helping individuals regain strength and independence through innovative techniques. This evening, they'll be discussing robotic spine surgery, covering its history in Memphis, the mechanics of how it works, the advantages it offers, and more. We're changing things up a bit tonight. Throughout the webinar, the doctors will be asking you some fun questions. When they do, feel free to drop your answers in the comments. It's totally okay if they're wrong. After a few moments, they'll reveal the correct answer. As always, feel free to submit your questions in the comments throughout the webinar. I'll be relaying them to Dr. Schroerlucke and Dr. Hauser so they can respond live. We have Dr. Schroerlucke here with us tonight. Dr. Hauser is at the hospital. He will be here shortly. So when he gets here, we'll kind of switch out and he'll take my place. Thank you for being here.
Yeah, thank you for having me.
Awesome. So I'll just turn it over to you if you just want to dive in.
Yeah, sure. So tonight we're talking about robotics and spine surgery, how we use the robot, when's the robot necessary, when should we use it, when we shouldn't use the robot. And I'm going to, give some, I've got some pictures available so we can really talk about what it does, what it looks like, because it is not that intuitive to think of spine surgery and robots, which is what I thought when I first heard that there was going to be a robot developed for spine surgery. I didn't really understand how it would be used, how it would be utilized. But yeah, let's get into it. You want me to ask the first question?
Yeah, go ahead.
So everybody's listening. What city in Tennessee was the first robotic spine surgery done in the state? We got a lot of great cities in Tennessee. We got a lot of great hospitals, a lot of great surgeons. So what city do you guys think the first robotic spine surgery was done?
Yeah, you can drop it in the comments, and I'll start reading those off once they come in. All right, Miss Catherine said Memphis.
Oh.
Nashville. Got
Come
two
on.
Nashville. Got another Nashville, have a Memphis. All right.
Those are good guesses.
Nashville.
Good guesses. So the answer is Memphis, Tennessee. The other question would be, so Memphis, we were the first city to ever do robotic spine surgery in Tennessee, and really we were the first ones to do it in any of our surrounding states, Arkansas, Mississippi, Kentucky, all around we're the first ones. Atlanta did beat us by a couple months, but we were really on the forefront of all this for a very long time. And so then the next question that I'd like everybody to try to answer, since robotic spine surgery is relatively new, what year did an ortho-south spine surgeon do their first robotic spine surgery? And you guys can guess on that. We're in 2025 now. So, when do you guys think the robot was first used in spine surgery by an ortho-south spine surgeon?
All right, 2021, 2023, 2018, 2012, 2022,
All right.
2015.
All right, it's pretty good.
You want to reveal it?
Yeah, let's reveal it.
You want to say it?
Oh yeah, so I was going to put the picture. Do you have a picture?
Oh yeah, sorry, here we go. Here's the picture.
So 2013 was the first spine surgery done in by an ortho south spine physician in Memphis. It happened to be at St. Francis Hospital, and that's me on the left. On the right is a neurosurgeon named Dr. Field, who has since retired. We did the first one ever performed in Memphis, and it was an incredible success. I didn't have a whole lot of expectations. I had been to a course to learn how to use it, but I wasn't sure how much I was going to actually use it and how much it would actually help me. But that was the first time we used it, and I'm not going to say I was hooked right away, but I thought that it had incredible applications. So then you know, we kept doing more and more of them. You know, we started getting better at it, and it takes a little while to get good at it. You know, by 2019, this was like a press release that we had where we had done our 500th. Was it 2019? 2019. We did our 500th case in Memphis in 2019 using the robot, and that's the robot right there in the center of the picture, and that's the team that helped us through those first 500 cases. And so, you know, since then, now we've got many more surgeons besides, you know, me doing these, including Dr. Hauser. He's done, you know, tons of these, and Dr. Eager does a bunch of them in our group, and the other people in town that do a bunch. So how many? We got another question, right?
Yes.
Okay. Do you want to ask this one, or should I?
Sure.
Okay.
I will.
All right.
So if in 2019 there was 500 cases, as of 2025, how many do you think Ortho South has done?
With the spine surgery cases with the robot in Ortho South, up to this point in 2025, how many surgeries, spine surgery, do you think we've done using the robot? And I will say this is pretty impressive, actually. You know, I was reading the other day that Mayo Clinic, you know, they did their first robotic spine surgery in 2019. You know, some other huge organizations didn't really start using the navigation in the robot until 2020s. So we were really on the forefront of this, which was a little bit luck, but, you know, just because the hospital, we all decided to get one. But, you know, we have as much experience as anybody in the country with regards to the robot. We got any guesses so far, Caitlin?
We got 1,200. We got 1,498. Mr. Allen said that. Parker said 2,000. There's 102. Correction, 1,002.
All right.
You want to reveal it?
Yes.
We actually have a slide for this one.
Yeah. So over 1,500 robotic spine surgeries performed by Ortho South physicians so far. So that's 1,500 patients that would have otherwise not had surgery with a robot and had the conventional way of doing surgery, which is, it's not that the robot is better or worse, it's just a different way of doing it and a newer way of doing it. But 1,500 is pretty impressive, you know, for little old Memphis, Tennessee, you know.
Yeah, so you said you were at the start of it here in Memphis. What got you interested in robotic spine surgery, and have you done any research on it?
Yeah, I mean, I think having the robot and, you know, having the opportunity to get the advantages of it, which is a lot of advantage, which we can get to as we talk, you know, less invasive techniques, more accurate with our screw placement, less radiation exposure for the patient and everybody else in the room. Very difficult patients can be really difficult to get the right x-rays in order to place our screws and perform the surgery that we are trying to perform. The robot really helps us out with those. Yeah, so we got pretty excited about it. In Ortho South, we did some research. We partnered with the robot company and did a lot of research for the first several years, trying to figure out, is the robot actually helping us? Like, is it helping? Are we using less radiation? You know, this study that we published in 2021, is that what it is? Mm-hmm. 2020, you know, showed that, you know, we were using less radiation while we're doing this and having very accurate screw placement with these lumbar fusion surgeries. And then the next study that we published talked about complication revision rates. Because look, if we're doing these surgeries and we're not getting equivalent or better results, then maybe we shouldn't even been using the robot, right? So we had to prove that the robot was not only successful in surgery, but also helped our patients long term. And so this study kind of helped us out with that. And then another one that we published, kind of similar, talked about reduction in complications, because if you have to go back in and do another surgery on somebody because the screw wasn't correct, or wasn't in the right position or whatever the case is, then you're really making patients go back for more surgeries, and that's just more problems for everyone. So this was another study that we published that kind of helped us out to prove that the robot is helping us with accuracy, but it's also helping with our results and decreasing our complication rates.
That's awesome. All right, to get into kind of some surgeries, I got a question again. What type of spine surgeries can you utilize the spine robot for? So if you have had surgery, you kind of have a leg up in this, but you can comment below, and if you haven't, you can guess. And like I said before, if you guess wrong, we'll let you know the correct answer.
Yeah, and I'll give some hints. So so the problem with the robot now in 2025, which we're working on improving all the different aspects that it can do for us, but right now the robot is used for placing pedicle screws, which are the screws that we place in the lumbar spine and the low back when we're doing, well, I'm about to give it away.
I was about to say, yeah. You got it. Your comments are fusion and spinal stenosis.
Perfect, yeah. So fusion surgeries are what we need whenever we're placing screws. So it's pretty rare that we're placing screws and we're not trying to accomplish a fusion in the low back or in the lumbar spine. But that is when we utilize the robot. The robot helps us with placing these screws, and these screws have to be very accurate, and I'll go through that here in a second, about why accuracy is so important and why they're difficult to place, just generally speaking. So yeah, so you're right. So lumbar fusion. So we do fusions with, people that have scoliosis, people that have stenosis, spondylolisthesis, all these conditions where we have to stabilize bones in relation to another. Also sacroiliac joint fusions. The SI joint is we're learning more and more about the SI joint, and we do a lot of SI joint fusions as well, and the robot is incredible for placing those screws as well. So this is an example of a patient that I had several years ago that needed a lumbar fusion, and so you can see that those bones are not lined up with each other. You can see those lines that are on the screen there, and so this patient has a lot of pain in the back and in the legs, and so our idea is that we need to line those bones up better, and then put screws with rods connecting the screws in order to stabilize that spine. And so I think so the next slide, so that's post-operatively, right? So you can see those bones are lined up really well on each other now. And Caitlin has done a great job of labeling this so we can tell what the screws are and the rods are. And you can see the screws are going into the bones, and then the rods are connecting the screws. So basically what's happening here is the screws are like our anchor points, and then the rods are holding the anchor points together, which are holding the bones together so that we can get a good fusion and get the result that we want.
And there's your result.
Yeah. So that's that same patient, and you can see those screws are very. You can see that they're very symmetric, right? The right and the left screws all the way down are very symmetric, which the robot really helps us with the symmetry too, because the robot's aiming these screws for us. Whereas when we do them without the robot, we can get symmetry like that for sure, but the robot kind of just helps us with that symmetric look of those screws. Which just balances the whole patient out, So like this picture is going to show the pre-op and the post-op. You can see how much more curvature the patient has leaning backwards, which is going to help their overall results long term, which having the screws in the right spot, all this matters to get these results that we're looking for.
All right, here's another example.
Yeah, so there's another patient that you can see the scoliosis. It's not a massive scoliosis, but this patient had a lot of stenosis too, which is narrowing of the spinal canal. And again, same kind of thing, right? We had to straighten this patient up by using screws and rods, and you can see those screws, again, very symmetric. We didn't put screws in every single level for various reasons, but you can see the patient is nice and straight now and doing better. And then that's what the patient looks like from the side. You can see that in the first x-ray, the bones are not lined up on each other, and then didn't have a lot of curvature backwards, but by putting those screws and rods now, we've lined the patient up. Good results, and the patient is doing really well. Which the robot helped us accomplish what we were trying to accomplish with this particular patient too. So you can see that pedicle screws are used. The screws are called the pedicle screws, and that's what the robot helps us with.
Yeah. So those are some real-world X-rays, patients you have dealt with. Here's just some animation pictures.
Yeah, so I think these are important just to show you the three-dimensional spine, without all the muscles and everything, and we're not looking through x-rays, but you can see that those screws and rods are placed in what we call the pedicles. And so on the top right picture, you can see those yellow structures. So that's the spinal cord, and those are the nerves coming off the spinal cord. So those screws, I can't stress enough how important it is for those screws to be accurate. You can see there's nerves all around them, in the middle, in between them, above them, below them, so they have to be perfectly placed. If you miss the pedicle and they're not hitting a nerve, that's just luck, right? But you're not going to get what the screws are supposed to do anyway, because they're not holding on to bone. So there should be the next slide kind of showing another picture of this. So this is an actual, vertebral body that's been taken out, and they put pedicle screws in it. And so what I circled there is the actual pedicle. And the bony part that you can see, the screws going through that bony pedicle, and then just on the lower side is the spinal canal. And so you can see how close it is. And the next picture shows another really good picture of how the spinal canal is in the center, that sort of triangle area where it's labeled spinal canal. Yeah, perfect. And then you can see where it's labeled pedicle screw. So you can see how important these screws have to be placed, how accurately they need to be placed. There's another picture here just showing that sometimes the width of the pedicle is really small. So this pedicle is only 5.7 millimeters, and to put a screw that's 5.5 millimeters in diameter in something that's 5.7 millimeters. Accuracy is really important, especially when you've got spinal cord just to the inside of it. So I think it's really good just to illustrate how important accuracy is with these pedicle screws when we're doing these spine surgeries.
So let's dive into the robot itself. There it is up there on the...
Yeah, so this is a typical setup for us. And this is a really good picture just because it kind of shows all the important aspects of it. Is this where we have it labeled? Is this one that's labeled?
No. The surgery one. Here you
go.
go.
Okay. Yeah, no. Go back.
Go back. Okay.
Yeah. So.
You may go back.
Yeah. Let's go back to that first one. Yeah. Sorry. Just to kind of give you a feel. So the thing on the top left is going to be our camera. Okay. It's going to be like looking over everything. The thing in the middle is the computer. So the robot is incredibly computer heavy. The software and the engineering behind it is just like beyond words when I first saw it. Now we're kind of used to this kind of stuff, but when it was made, nobody ever thought of this before. And then on the right is the operating room table and the actual robot. And so we go to the next slide, we'll kind of understand it a little bit more probably. So that's the actual robot on a patient. And so you can see on the top right is the planning that was done before the surgery. So what we have to do is we have to virtually place these screws on the computer. So we have a CT scan beforehand, virtually place the screws, and then the robot's going to aim us in the right position. And so that's the robot aiming us onto the patient to tell us where that pedicle screw needs to go. So the top, so this is actually a great picture. So the top is the robot that I used in 2013 until about 2018 or so, and that was the original spine robot. And it's like, we call it a Coke can because it's this little thing and it would move into position. We had all these attachments to it to get us, and it was incredible. But you can see what we have now on the bottom. I mean, the newer robot is so much bigger. It has, the range of motion is completely different. It's much stronger, so it's not going to move as you're putting screws in. And so I kind of have an analogy here. That top thing is kind of like do you have that picture? It's like the Walkman, back in the 90s, and then now we got the iPod, down at the bottom. I mean, it's just a completely different thing, newer technology that you couldn't even you can't go running with that thing on the top. Have you ever tried to run with a Discman? Yeah, you can't do it. Yeah. So this is an actual setup in my operating room from either this week or last week, and I've labeled all the different structures. So you got the X-ray monitor on the top, so we can see where the screws are going. The robot computer is labeled on the top right. The actual robot is labeled, and you can see the robot is draped out, because it's in the operating room field. So we do have to drape it, make it sterilely drape the robot. I labeled the patient just in case we were confused, and then the surgeon, that's me right there, so I labeled that one too. But just kind of know what the setup is of the robot. And so first what we have to do is we have to take x-rays to make sure that the computer knows where the patient is in relation to the robot. Okay, so once it knows where the patient is in relation to the robot, then it knows where the bones are, and it knows where the pedicles are, and it knows where these screws that we virtually placed. So this is an actual patient that we did, and that's the screws that we want to put in. So before the surgery, I go onto the computer and I place the screws where I want them. And the idea is that we're going to take that information and then translate that to the patient and put the screws exactly where we want to put them, like we did virtually on the computer. So the next picture is, okay, so this is a video of me. So after the robot gets into position, then,
hold on 1 second.
Yeah, sure.
There we go.
Just to kind of set it up. So what I have to do now is I have to drill my hole through the pedicle. So the robot's already in position. I'm drilling a hole through the pedicle. I take the drill out. Then I use this tube that goes down through the hole that I just drilled. Then I put a wire down through that tube, and that's going to go into the pedicle where we want it to be. Now I pull the other things out, and then I remove the tube, and then now the wire's in position of where we want to be. So at this point, what I would do is I would do all of the pedicle screws that we need to place. We'll get those wires in. We'll check X-ray, make sure that they're in the right spot. If they are, then I put a screw over top of it. And the screws are cannulated, so there's a hole in the screw, so I can go right over the wire. And so what this is, the picture on the left is what we wanted it to look like, right? And the picture on the right is what we did end up looking like on the actual X-ray. And you can see that's exactly the same. I mean, the only difference is that we do put the screws in a little bit deeper on the computer, because it's not a real screw. It's just a colored thing, But in real life, we don't take it all the way down as far as we do on the computer. So that's the only difference. It's not quite as deep in there, and that's why the screw heads aren't touching at the end. But we don't want them touching. So this is actually, you see, perfectly symmetric. They look exactly like we did before. So the robot did exactly what we wanted it to do. And this is what it looks like from the side. Same thing. So the picture on the left is our virtually placed pedicle screws, on the computer, and then the picture on the right is the actual X-rays that we took during surgery earlier this week, and the screws look great. So this is just an example I put in there of some reasons why the robot is so helpful. So this would be a pre-operative CT scan that we had, and we're trying to place these screws. And this is a really unusual looking bone. Okay, there's a big black area where that on the left side, and what that is where there's a bunch of bone missing. And for various reasons, this patient, I won't really get into all the details, but was missing a bunch of bone right through there. So we had to make sure that we put these screws right through that and then all the way into the white bone part. Because if we don't put the screw all the way deep enough, then we're not going to get any purchase into that bone. The screw's just going to pull right out. And then it helps us too, because on the other side, we know that it's really hard bone all the way in. So we can aim the screws how we want beforehand to make sure we're putting the screws exactly where we want them to be. Since every patient is so different, right? So that's just a really good example of, of a specific time when you need, the robot really does help us,
So to get that picture, I know you order a CT. Is there any other way to get that imaging, or is it CT is the best route right now?
Yeah, so right now we have to have a CT scan before we do the surgery, because we have to have that bony anatomy that a CT scan can only give us. At some point we will be able to do it with MRI. Right now we can't, but at some point we will. And we are at the forefront of working on that, like as we speak. Like before we started this meeting, I had a meeting talking about getting MRI so that we can use that information of the MRI that will give us the bony details in order to use MRI. Because everybody has an MRI. The problem with it now is that everybody already has an MRI, then I have to get a CT scan on them also. Which a CT scan only takes 5 minutes. It's not that big a deal, but we already have an MRI. So eventually we're going to be able to use MRI to do this, but nobody's there yet in the whole world. But at some point we will be.
That's cool.
So why?
So why? Why the robot? Why not the traditional route? I feel like you've hammered on accuracy.
No.
But
so look,
I
mean, accuracy is probably the number one reason, right? The pedicle screws have to be placed in the right spot, and the robot helps us with our accuracy. So that has to be number one, especially with difficult patients. Difficult anatomy, patients that have had prior surgeries, it's difficult to see the pedicles on X-ray, and if you're trying to do minimally invasive surgery, which I should back up and say most robotic surgeries are done minimally invasive. If you're doing a traditional open approach surgery, the robot is still effective, but it's probably more helpful in the minimally invasive route. So you're doing a minimally invasive surgery and somebody that's had prior surgery and difficult anatomy, the robot is so helpful because it can like distinguish between all the little facet joints versus all the little bony details that are now disrupted because of the prior surgery and help us get those pedicle screws in the right spot. I would say in the minimally invasive sphere, the robot does help us make smaller incisions, okay? Because it's going to be accurate. We're going to know where to make the incision based on where the robot is telling us to put it. Instead of us making the decision and then deciding where the screw is going, it's doing that for us. So it's keeping our incisions as small as possible. I would say one of the biggest things too is radiation exposure. So, I did a study on this when I first started using the robot, and we found that we were using 80% less radiation during surgery. And so 80% less radiation to the patient is huge. 80% less radiation to the nurse in the room, the anesthesiologist, the scrub tech, the assistant, me, that over the course of a 20, 25-year career is massive. So, radiation exposure is a huge topic in orthopedics and in neurosurgery and in spine surgery, and for patients too. I mean, the less radiation, the better. So that's 80% less radiation per surgery is a huge advantage of the robot. I would say another thing is, patient outcomes. We're proving that patient outcomes are equivalent, if not better. And that's been proven in many studies. And so, that's a huge thing. That if we can keep the patient outcomes really, really great patient outcomes, then that's one of the main reasons to do it, right? That's our whole goal in going in there to do the surgery. And then the other thing would be time. I would say that one thing that some surgeons get hung up on is they think it takes too much time. And at first, it does take more time to do the surgery when you're learning how to do the robot. Just like anything else new, it takes a minute to get faster at it. But again, speed isn't our main priority during surgery. It's definitely not mine, and nobody that I know, But what we have proven, and we've shown this, that it does become equivalent, if not a little bit less in time, right? So it's not something that's going to like take somebody from, a patient that's going to take 3-hour surgery to a 2-hour surgery. If it's a 3-hour surgery, it's still going to be a 3-hour surgery, maybe 2 hours and 50 minutes, right? But it still takes the time to do the surgery. So it's not a huge time saver, but it is equivalent in time. And when you get all the other benefits, it makes sense for me, from my standpoint.
What's the significance on time, like for everybody listening?
Yeah, I mean, for time for patients, look, the longer a patient's under anesthesia, the more complications are going to come from anesthesia, and I think that makes sense to everyone. If you're laying in one spot under anesthesia for 10 hours versus 30 minutes, your whole body is under a different type of stress during surgery. Your blood clot risk, your pneumonia risk, all these risks go up the longer you're under anesthesia. So, if you can do surgeries in a quicker amount of time, that's probably that's beneficial. Mm-hmm. But you have to balance the time of how long it takes surgery and the successfulness of the surgery and how well you've done the surgery.
Yeah.
So time does matter, but it's one factor in many, I think.
Yeah, for sure. So I had a question when we were reviewing this information, and we talked about all the whys, all the advantages. Are there any disadvantages?
Yeah, I mean, that's a great question. I would say from just a strictly surgery standpoint, like I have surgery tomorrow that I need to put pedicle screws. Should I use the robot? My answer is yes, almost every single time. The time when I would say no would be is if a patient can't have a CT scan or doesn't have an ability to get a CT scan for whatever reason, then I can't use the robot. But strictly speaking, you're going to use pedicle screws or SI fusion screws or something, the robot is extremely beneficial. So I would say there's no negatives on that standpoint. I would say the biggest negative to the robot, though, is that the robot is a computer. And everybody uses computers, and they don't always work, right? So if you are going into a surgery and the only way you can complete the surgery is with the robot, then that is a negative because you have to be ready to do the surgery without the robot. And one thing that I see kind of trending across the country is that some programs are training, spine surgeons with the robot. And I think it's good to train surgeons with the robot, but they have to know how to do surgery without the robot first, and then supplement that with the robot. Because if you learn with the robot first, then you're going to be in a situation one day where the robot's going to break in the middle of surgery, and maybe you're not ready to, or well trained enough to do the surgery without the robot. So I think that is a negative coming down the pipe, just like with any of this technology. Like the more technology we have, we get really good with the technology, but then we become really reliant on the technology. The good thing about most people that are out there now, like we all trained without a robot. We never heard of a robot until we were however many years into our career. And so, you know, if the robot doesn't work tomorrow, we don't use it, and we can do fine. We do the same surgery, same results, you know, all this kind of stuff. So I think that's probably the negative about the robot.
Awesome. So let's just dive into some patient questions. Do you have anything else you want to talk about before we dive in?
I mean, I could talk about robots forever. I mean, spine surgery and robots is what I've my whole life.
Yes. All right. Well, let's start. Let's see. When would you not use a robot in a patient? We talked about that a little bit about like if the robot's not working, but is there any kind of, I guess, anatomy reasons why you wouldn't?
I mean, there are occasions when the robot is not able to, sometimes if people have a lot of metal, so there's some things called spinal cord stimulators where people have a big battery, and if the battery is lying right over top where the pedicles are supposed to be, then the robot is going to have a hard time distinguishing or getting around that battery. So that would be a time when the robot, when you try to use it, but you can't, right? So I don't know if there's a time when you're putting a pedicle screw in and you say, well, the robot's gonna be detrimental to this case, but there are times like that when there's too much metal, or for some reason you can't get a good enough x-ray and the robot can't distinguish between the anatomy, then it is certainly possible that the robot wouldn't be able to help you with the surgery. But to answer, is there a time when you won't use a robot and you're putting pedicle screws in? I would say no. I will say that I do think that in the future we'll be able to use the robot for all spine surgeries, right? Like why not? Like why can we not use the robot to help us with laminectomies and microdiscectomies and ACDF neck surgeries and all of these surgeries? We should be able to use the robot, and I think we will, you know? We just are not quite there yet, you know?
So for the robotic surgeries, are you primarily or only in lumbar spine? Do you do it further up?
So you can do thoracic spine too, so that's the middle back. The neck, it's pretty much off-label to use in the neck. I mean, there have been people who have done it. I mean, I've done it a handful of times in the posterior neck, and it's really helpful. But the neck is so much more mobile. Mm-hmm. You know, the low back, when a patient's on the table, they're not moving. The neck is more mobile. The structures are smaller. They're more mobile too. So it's a little bit harder in the neck, but we're getting there. I mean, we are starting to use them in the posterior neck. In the front of the neck, we're not yet, but one day I think we will be able to. That's
awesome. All right. Would you be able to use it for foraminal stenosis?
Yeah. So I think if you're fixing foraminal stenosis with a decompression type procedure, which is like a laminectomy or foraminotomy in this particular case, not really. Like we're getting there. There are some early people that are starting to use this for laminectomy type surgeries. I don't yet. Now, if you're fixing foraminal stenosis with a lumbar fusion, which we do a lot, okay, because foraminal stenosis, when the foramen where the nerve is exiting, it's really small, and so one way to get that bigger is to open up the disc space. So you separate the bones from each other, and that opens up that foramen so the nerve has more space. So if you're doing a fusion in order to correct that, then yes, we would use the robot for the screws, yes.
All right. Mr. Paul said, what is the average recovery time and pain level after surgery?
Yeah, so definitely every lumbar fusion is different. Okay, so you have a one-level lumbar fusion versus a scoliosis surgery from the top of their back all the way down to their sacrum is very different surgeries. But generally speaking, the night after surgery is pretty tough for people. The low back is very sensitive. Those muscles are responsible for every single movement that you make. So you just roll over in bed and now your incision is hurting like crazy. You know, I tell everybody, if you have like wrist surgery, you put it in a cast and then you can roll over all you want and the wrist doesn't really hurt, you know, but your back is going to be hurting. So the first night after surgery is pretty tough. The typical recovery after lumbar fusions is about 3 months. Obviously this stuff isn't written in stone. Yeah. But the first 2 weeks are the toughest. People get a lot better after those first 2 weeks. And then at that 6-week point is when people really start recovering, so that when they're 3 months, people are doing pretty well usually.
All right, so next question is from Mr. Allen. Is there anything you can do for arthritis in the spine? It's kind of a generalized question.
Yeah, I mean, arthritis is tough, right? I mean, just if you think of arthritis everywhere, like if you have knee arthritis, we don't really have any way to stop knee arthritis in 2025. Like we have stem cells and things that we try, but they're not, if you get stem cell, the arthritis doesn't reverse itself. If you have arthritis in your hip, it doesn't reverse itself, right? So our treatments for knee arthritis and hip arthritis, at the end of the day, we try physical therapy and all this stuff and injections and things, but at the end of the day, you get knee replacements and hip replacements. And so we don't have great treatments anywhere for arthritis, you know, in terms of stopping it. The spine is no different. One of the problems with the spine is that we have arthritis in the front of the spine, which are the discs, and we have arthritis in the back of the spine, which are the facet joints. So we have and plus we have all these different levels. You know, you got 6 levels and 5 levels in the lumbar spine. 12 levels in the thoracic spine. The lumbar spine connects to the sacrum. So you have all these opportunities for arthritis in the front and the back. And so once you get arthritis in the spine, it is difficult to get better, right? I mean, anti-inflammatories, physical therapy, injections, things like this. But then at the end of the day, a lot of times for arthritis, if we end up getting motion and things and we can't get people better, then lumbar fusions are kind of our end-all answer to a lot of these problems.
Awesome. So next question is the recovery quicker than it would be without the robot?
Yeah, I think yes, definitely. If you're doing minimally invasive surgery, the robot's helping us with smaller incisions, right? We're not having to take a long time to put the screws in the right spot. We're not, putting the screws in and having to take them out and put them back in again because we're missing them, because we're missing the pedicles. We're not taking as many x-rays, right? So there's a lot of things that could decrease recovery time with the robot. I wouldn't say that the robot takes us from, a year recovery to 3 months recovery though, right? Like it's still spinal fusion surgeries, and so the robot definitely decreases our recovery time, but not some crazy amount that's going to really move the needle from one patient to the next. Now, unless somebody's going from an open procedure, where you're opening up everything and exposing the whole spine and doing surgery, versus using the robot using minimally invasive. Now that has been proven to be way less recovery time if you're comparing those two things. But if you're doing it minimally invasive without the robot or minimally invasive without the robot, the recovery time is probably pretty equivalent, honestly.
Next question. These are all really good. For fusion, do you insert a cage first?
So, very good question. The answer is yes, most of the time. I do basically every single time. Like I haven't done a lumbar fusion without a cage in many, many, many years. But it's still acceptable in spine surgery to do certain spine fusions without a cage. The cage is going to increase our height in the front, which is going to help our lordosis, it's going to help our fusion rates, it's going to do a lot of things for us, but it's not written in stone in spine literature that says you have to put a cage between the bones. But most people are doing that these days. But you don't, spine surgery is a little bit weird in that we don't have clear guidelines on all of our surgeries, right? And that just illustrates how complicated the spine is. But the short answer is, yes, I put a cage every single time, but you don't necessarily have to, depending on the anatomy, right? Depending on the situation.
For those who don't know what a cage is, can you just briefly mention that? You're good.
Yeah, so the cage is going to be put between the bones. So when you do a fusion, a lot of times you'll take the disc out, and then you have to put something back in there. And so you'd put a cage in, which is going to hold those bones apart from each other. And then in that cage, we put bone graft. Okay, so we're trying to get a fusion between the vertebral bodies, And in order to do that, you have to take that disc out. Because if you don't take the disc out, why would bone grow in that disc space, right? So you have to take the disc out, put bone graft in there, and we put a cage in order to put the bone graft in to hold that space open. Then we put the pedicle screws in using the robot. So that's what a cage is.
Perfect. Looks like the next question is from Mr. David. Can robotic surgery address degenerative disc disease?
Definitely, yes. I mean, degenerative disc disease is extremely common. We do fusions for degenerative disc disease, and the idea is that you're doing a fusion to take a degenerative disc, which is arthritis, right? The disc is worn out from wear and tear, and you do a fusion. So the robot is a great way to treat degenerative disc disease. The problem is if somebody has degenerative disc disease at every single level in their back, and and not one is specifically causing all the problems, then it becomes a very complicated thing of what surgery does this patient need. Do they need fusion up their whole back, which isn't that great? Do they need one level of fusion, or maybe it's best if they don't have any surgery altogether, right? I mean, this stuff is, every single patient is so different, but I mean, the short answer is yes. The long answer is it definitely, if surgery is warranted, then a fusion with a robot would be a good option for that.
Do you do revisions with the robot?
Yes. Revisions with the robot is incredible because the anatomy is so difficult to distinguish. And so I do think that when you're doing revision surgery, the robot is extremely helpful. And sometimes I'll have to remove screws that have been placed a long time ago and put new screws in and put screws above, and the robot is so great because I can look at the preoperative CT scan, use the robot to help me find out exactly what kind of screw was in there before, the size of the screw that was in there before, so I can plan what kind of screw, when I take those screws out, what size screw am I going to need to put back in. I usually like upsize by 0.5 millimeter, and so the robot's really helpful with revision surgeries.
Awesome. Miss Cynthia says, which facility has robots?
So most in Memphis, St. Francis Park has a robot. Methodist Germantown has a robot. I don't know about Methodist University or if Regional 1 has one. Baptist East is hopefully getting one pretty soon, and Baptist Collierville has one. I don't think none of the surgery centers in town have one. I think there are a couple of surgery centers in the country that have them, and that's something that we would love to do at some point at our Ortho South Surgery Center, but not yet. So what I just told you guys about the hospitals, there might be other hospitals that have it, right? Those are the ones that I know about.
Locally, yeah.
Yeah.
Post-surgical mobility with a fusion. I know there's different levels of fusion, so.
No, it's a good question. I think that, so the easy answer is that whatever levels you had fused will not move at all post-operatively. So, which, is like kind of obvious, right? But how much that affects your overall motion is usually pretty minor. Most people, if they are going to have a lumbar fusion, are not all that mobile at the level that they're working at anyway. I mean, some people can have a big instability type situation, but that's abnormal motion, right? So that you don't want that motion. So you're fusing that, you're actually making that part better. But your overall motion, most people do not notice a motion problem after surgery. Even if people that have 3 levels fused in their lumbar spine, most regular people that have regular jobs and do regular stuff, unless they're yoga instructors or gymnasts or, super high level athletes or something, they're probably not going to notice the motion difference. So much of our motion comes across our hip joints, like you and I are sitting right now, right? And our legs are completely bent, right? But our backs are straight, right? And so most of our motion comes from our hips. When we have people that we've fused that have scoliosis surgery, we fuse from their head all the way down to their pelvis, and they can still bend over and tie their shoes, right? Because their hips move so well. So motion is something that we worry about, but most people don't really notice it, and so I'll leave it at that.
Yeah.
There are some other things to talk about motion, but I think that's enough.
That's good. How soon can you return to work? So I know you mentioned the 3-month mark.
Yeah.
Is that kind of?
Yeah, I mean, that's kind of a general answer. I mean, I think that if your job is, if you have a computer job that you work from home, right? Versus if you're a firefighter or a police officer, right? So these are very different jobs that require very different things. So if you have a job where you sit at a desk and work from home, then, I mean, I have people going back in a couple days or a week, or 2 weeks, if they're motivated to go back. Obviously, if you're a police officer or a firefighter or a construction worker or somebody who lifts heavy things, and you're not going back for at least 3 months. And if you're in charge of somebody's life with your body, like a police officer is, I mean, you're probably not going back for 3 months, 6 months, something like that, right? It just takes a long time to get fully back. So it is variable based on the patient. The difficult ones are the people that have like these in-between jobs, right? Where you're not fighting fires, but you're also not working at a desk, right? Like I had a patient today who's a teacher, and it's tough, right? Because a teacher has to move around and carry things and go from class to class. But it's not like a desk job, but it's not a super physical job. It's kind of in between. And so, they kind of have to play it by ear. But I tell everybody to plan on taking 3 months off. And then if you can go back earlier, go back earlier,
Yes. All right. Next question. Let's see. Instead of fusion, can you simply replace the disc with an artificial disc?
Yes. So we do have disc replacements. Disc replacements haven't, when disc replacements first came out, when I was in residency in medical school, I personally thought that it was going to be the end of fusions. I thought nobody would have lumbar fusions anymore. And it hasn't panned out that well for us. The spine is much more complicated than we even thought, even though we knew it was super complicated. So disc replacements in the cervical spine are very effective. We've proven that they are doing a really good job. They're still not perfect, but we're seeing a lot of good results. In the lumbar spine, one of the problems is it's difficult to get a disc replacement in. You have to go through the stomach to get a disc replacement in, and that's sometimes not possible depending on patients' anatomies and where their aorta and vessels are. If they've had prior abdominal surgery, then it's very difficult to do. The other thing is that the disc replacement encourages motion. So like I said earlier, if you have a patient who has too much motion and you put a disc replacement in them, you're encouraging the problem that is the problem, right? The problem is motion, and now you're accentuating motion. So now you haven't really fixed the problem. The other issue with disc replacements is that it doesn't address the joints in the back of the spine, which I mentioned briefly earlier, which we call the facet joints. So you do a disc replacement, maybe it'll fix the disc pathology, but if they have a bunch of arthritis and degeneration in their facet joints, now they're moving across these facet joints that are arthritic, and so they're still going to have pain. So disc replacements they are out there, and they're used occasionally, not as common as we all hope, but maybe one day. And maybe one day we can put in disc replacements with a robot, which would be great.
Yeah. Are robots often used for anterior surgeries? I know you said no for the...
Yeah, so not yet. At some point I think we will. They're used, a different type of robot is really common for abdominal surgeries. The urologists and the OBGYNs and the general surgeons use the robots like crazy to do different surgeries because they can get in there in a space and work. They kind of blow up the abdomen, and then they can get these robots to do work for them. We don't use the robot for our anterior surgeries yet. Some point maybe, we just haven't found the application for it quite yet.
Gotcha. And then someone else asked if you were located in South Haven, Mississippi, like for seeing patients.
Yep, so not me. No, but we have plenty of spine surgeons down at South Haven that'll see anyone that wants to see anyone in South Haven. But yeah, I'm not down in South Haven.
Awesome. And last comment, we have a patient who just compliments you as a great doctor, that you've been her back surgeon, and her surgery was very successful.
Oh, great.
So just overall, a great doctor.
Oh, that was nice. Thanks.
All right. It looks like that is it. One more question, because I'm actually curious about this one. How big is the robotic spine incision? Is there like an average?
Yes, that's a good question. So for each screw that you have to put in, there has to be enough space for the screw, which is about, a little bit less than an inch probably. The problem is you have to put, if you're doing an L4 and L5 fusion, the screws have to go in L4 and the screws have to go in L5. So there does have to be enough space between L4 and L5. Some people will make an incision at L4 and an incision L5 with a little space that much in between, and sometimes I'll do that, but most of the time that can cause more problems because now that piece of skin doesn't get blood supply, and now you got a bigger problem with our wound healing. So, sometimes the incisions are only this long, really small incisions for a 1-level fusion. But, if you do a much bigger surgery, I mean, sometimes you need bigger incisions. A lot of times what we'll do is which the robot really helps us with this, is we'll put, an incision up here like this. If we're doing like a 4 or 5 level fusion, make an incision where 2 screws will go in, and then an incision down here where 1 screw will go in, then another incision down here. So that's kind of nice where you can kind of put some smaller incisions, and then we thread the rod underneath, which is easier said than done, as you can imagine, underneath the skin. So yeah, it just depends on how many levels the patients have and how many pedicle screws they have to have put in.
Awesome. Well, you've got a few more comments just saying how awesome you are as a doctor, that you're terrific, a great surgeon and great person.
That was probably my mom. She's probably on.
It wasn't, but I know she thinks that too. So closing us out, I know you could talk forever on about this, but is there anything else you want to mention about just spine surgery in general before we close?
Yeah, I mean, look, I think spine surgery is complicated. I mean, not many people go into spine surgery because it's difficult. It's difficult surgeries. We have difficult anatomy. It takes it's more challenging to get our diagnosis correct. Post-operatively, it's tough for patients. But I love it. It's challenging for me, but I love the surgeries. I love talking to the patients. I love the patients that are, we have a lot of patients that aren't doing very well and they're in a lot of pain, and so I like being there for them. I wish Dr. Hauser was here. He's the same as me. Like we're like the same. We're like the same. The way we treat our patients, the way we do our surgeries. But it's difficult. But it's rewarding for a lot of reasons. But it's hard. When you have a spine surgery, you have to recognize too that the expectations, are not that you can get back to doing things like you did when you were 25 years old, right? Like that's one of the problems. Like if you do a lumbar fusion on somebody and they can't walk to their mailbox, the end isn't that they can run 5 miles, right? Like and run a 10K next week or next month, right? Like the goal is that they can walk to as many mailboxes as they want, right? But they walk at a regular, pace, but that our goals are to make people better and more functional. But it is really hard to make people somebody that they were 50 years before that. And so I think I try to impress that on my patients that, that we're making you better, right? But it's not perfect. Like God did not create our backs to have screws and rods in there for a reason, right? It was supposed to have motion. It was supposed to be balanced and all these things. And so when you put screws and rods in there, it's not perfect, but it's better than it was. And if you're a patient and you have a spine surgery, as long as you recognize that, like, and that's why we don't do surgery on people that are doing pretty well, right? Like if you're doing pretty well, then you come see a spine surgeon. The spine surgeon's probably like, well, I don't think you should have surgery because, you're a 2 out of 10 pain. If we do surgery, maybe you'll be a 1 out of 10 pain, and I don't know if that's worth it. Now, if you're 9 out of 10 or 8 out of 10, we can take you down to 2 or 3 out of 10, that's a pretty happy patient. That's a successful surgery in our book, So I would say that about spine surgery, that it is, pretty complicated, but also rewarding and, difficult and all the things. But, but this technology is great. I mean, we are learning so much about spine surgery. I mean, every day our technology is improving. What's happened over the last 15 years in my career versus, the 15 years before that. I mean, the people before me didn't even know what pedicle screws were, and now we're using robots to do them. And then what's going to happen 15 years from now, So it's really exciting to be a part of that too. And at Ortho Spine Institute, we are on that forefront of like making this stuff better. And so it's a pretty exciting time to be a part of this stuff. So. Yeah,
that is exciting. All right, well, we are closing out. Thank you, everybody, for joining us. Next month, we'll have Dr. Lee Sigler back on with us. She'll be discussing women's spine health. Thank you for joining, and thank you, Dr. Schroerlucke, for taking time to do this.
You're welcome.
All right, stay tuned for a few announcements about how to see either Dr. Schroerlucke, Dr. Hauser, or any of our providers.